Hello, thank you for joining today's NCCN webinar for patients non-small cell lung cancer. My name is Tanya Fisher, and I am the moderator for today's webinar. NCCN stands for National Comprehensive Cancer Network. NCCN is a not-for-profit alliance of 33 leading cancer centers across the United States devoted to patient care, research, and education. NCCN Foundation is a nonprofit organization that raises funds for NCCN patient resources, including new and updated patient guidelines, as well as patient webinars. These are funded using financial support from generous donors. The NCCN guidelines for patients are based on the NCCN clinical practice guidelines used by healthcare providers worldwide. They explain the same options for cancer care, but are written for patients and their caregivers, family, and friends. You can view and download free copies of the guidelines for patients from the NCCN website. High-quality printed copies of the book can be purchased through Amazon. And if you ordered a free book when you registered for this webinar, you should receive it shortly. The NCCN webinars for patients complement the NCCN guidelines for patients. They cover a series of topics discussed by expert presenters. Viewers have an opportunity to ask questions at the end of the presentation. This brings us to the presenters for today's webinar. I'm very pleased to introduce Dr. Dawn Owen. Dr. Owen is professor and consultant in the Department of Radiation Oncology at the Mayo Clinic Comprehensive Cancer Center. Following Dr. Owen, we'll hear from Elsa Luce. Elsa is a physician assistant in the Department of Thoracic Medical Oncology at the Mayo Clinic Comprehensive Cancer Center. And our third presenter today is Terry Shapiro, patient advocate. And now I will turn it over to Dr. Owen.
Welcome, everyone, and thank you for joining us today. Non-small cell lung cancer is a very near and dear topic to my heart. My father actually passed, unfortunately, from non-small cell lung cancer stage 4 more than 20 years ago, and this drives what I do today. And I'm a radiation oncologist, and I'll tell you a little bit about generally what to expect when we talk about non-small cell lung cancer. So what does it mean if you've been told you have lung cancer? So we're going to start with talking about kind of general things. What types of symptoms can occur? How do people come about with being diagnosed? So symptoms can include coughing. So you could have a cough that just doesn't go away. It's a really nagging cough, or you may start to cough up blood. Some patients start to note that they're having more trouble breathing. They're huffing and puffing more than usual. Unexplained weight loss can happen, where appetite goes down, you just kind of feel blah. Having pain in areas that they just never go away. They're waking you up at night, feeling really, really tired. But one of the key things I want to highlight is that many patients with lung cancer don't have any symptoms. And this is important to note because many patients can actually undergo screening CT for early detection of lung cancer. And so what we see is that this is a non-invasive scan. It's a CT scan where we get a 3D image of your lungs, and we can find lung cancer early, and we have a higher chance of cure when we find it that way. And this is just a picture of somebody who is going through a CT scan right now. So if you know anyone, or if you yourself meet these criteria, I would strongly encourage you to talk to your primary care physician. It is covered by insurance. Patients who are 50 to 80 years old who are smoking right now or quit up to 15 years ago. And there's a formula to calculate how many packs a day that we use to estimate risk that you can talk to your doctor about. And I've included that formula in your handout. You go through this low-dose CT screening scan, and screening cancer does save lives. And this is actually an infographic from one of my colleagues where, every day in the US, an average of more than 400 people die of lung cancer, and screening does save lives, just like a colonoscopy. But this is way better. You don't have to do a prep. It's just a non-invasive CT scan. So I would encourage anyone who knows anyone who meets these criteria to also think about it so we can detect it earlier. So How do we diagnose lung cancer? Basically, the first thing we need to do is we need to find it, and we find it by doing scans. And so we talked about that CT scan, which is a 3D picture. A PET scan is a whole body scan where they give you some radioactive sugar, and we often do this. Sometimes we have to get a scan of the brain to make sure it hasn't spread to the brain if it's a higher stage. And we'll talk a little bit about staging later. And then we have to get a piece of the tumor to figure out what type of lung cancer it is. And today we're going to talk mostly about non-small cell lung cancer. And that can be done. This is a picture of a bronchoscopy where they put a camera down into the airway and they snip a little piece so we can look at it under a microscope, or percutaneous biopsy. So that means that a patient goes in, they put a needle into the tumor from the back or the front, and a radiologist does this so that we, again, can get a piece of the tumor to look under a microscope to make the diagnosis. So what are the different types of lung cancer? So there's two types, small cell and non-small cell. We are not going to talk about small cell lung cancer today. That's treated quite differently. We're going to talk about non-small cell lung cancer. And it's called non-small cell lung cancer because when we look under a microscope, the tumor cells look a little bit bigger, whereas the small cell lung cancer cells look very small and blue. And so when we look at it, the first thing the pathologist, who's the person looking at the slides under a microscope, determines is what type of lung cancer it is. And if it's a non-small cell lung cancer, we need to figure out what subtype it is, because the subtype makes a big difference in the types of drugs and the types of treatment we're going to do. And the three major types of non-small cell lung cancer are adenocarcinoma, that's the most common type, and you can see that in the blue in this pie chart. Squamous cell carcinoma, which is the next most common, and the least common is the large cell carcinoma. So what does staging mean? So now let's say somebody's told you, okay, we got a piece of the tumor. We know it's a non-small cell lung cancer. We've told you what subtype it is. And so what's important for us to know is the stage. And stage means how extensive is the cancer? Where has it gone? So a stage 1 is lung cancer that's just in the lungs. It hasn't gone anywhere. It's one spot in the lung, and it has to be less than 4 centimeters, which is about an inch and a half. And in medicine, we do use the metric system, so everything will be in centimeters. In stage 2 lung cancer, the cancer has spread to the lymph nodes, which tend to sit along the airway, or the tumor is a bit bigger. It's more than 4 centimeters, but less than 7 centimeters. And 7 centimeters is approximately 2.5 inches. And then we get to stage 3, where the cancer may have spread to the middle of the lungs. And so we have lymph nodes that sit in the middle of our lungs along our airway, or it's bigger than 5 centimeters or 7 centimeters. And so that's a stage 3. And then a stage 4 is when lung cancer has spread. And it has spread either to the lining of the lung, to other organs. It's very big. And this is why we do, for more advanced stages, we have to check the brain, and we also use that whole body scan. We talked about the PET scan to look at where things have spread. So the types of treatment depend on the stage. So if the lung cancer is only in the lungs and it's a stage 1 or a stage 2, then often we think about doing surgery, and surgery is the standard of care. So if patients are able to get surgery safely, we do recommend that, or radiation treatment. And I will talk a little bit about radiation treatment. That is actually the type of oncologist that I am, where I use radiation to treat cancers. Stage 3 is when it's in the lymph nodes. Then there's lots of different options. Often it's a combination of multiple treatments: surgery, radiation, and drug treatment. And you'll hear from my colleague Elsa Luce, who's a specialist in delivering drugs and different types of drugs for lung cancer. And then when it's stage 4, meaning it's outside of the lungs and in the lining of the lung, then we're really looking at using drug treatment to get control of the cancer. And then we may spot weld things with radiation directed at different spots, and we will talk a little bit about that. So how do we decide which treatment is best? It's very confusing sometimes. It's very overwhelming to be told that you have lung cancer. And there are many treatment options, and I generally listed some just before, showing you that there's lots of different things we can do. And this is where having a team is important. It is really important to meet with a team of providers, and you'll meet lots of different people. So the first people you might meet would be pulmonary medicine. They are the lung doctors who specialize in things like emphysema or having trouble breathing. They're often the ones that do the bronchoscopy, which is a camera exam that we talked about, where they can get a piece of the lung tissue or check the lymph nodes. You may meet with a thoracic surgeon, and these are surgeons who specialize in lung surgeries. Medical oncology, which are doctors who specialize in giving drugs for cancer. Radiation oncology, which is I'm an oncologist who specializes in using radiation to target tumors, and radiology, and they're the people who read the scans, but also do procedures such as the percutaneous biopsy we talked about, where we put needles into things to get a sample of the tumor from the outside. And this is actually a picture of our lung tumor board when we used to meet in person. Now we meet via Zoom, which many more people can come. And he's actually one of our nuclear medicine and chest radiologists. He's a surgeon, and this is one of our medical oncologists and our pathologists. You don't meet the pathologists. They're the people who look at the slides under the microscope to make the diagnosis, but they're very important also to the team. So when do we kind of decide to cut things out or give radiation? And for stage 1 or early stage 2 lung cancers, this is often a discussion. And as we discussed, if you are a candidate or if your loved one is able to have surgery and it's safe, we do recommend that you have things cut out, and that is under the NCCN guidelines. As Tanya talked about, there's a group of experts that come together looking at the best evidence, looking at what serves patients best, and often we will recommend surgery first. But there are some patients who really can't have surgery. They have a lot of heart problems, or they have a lot of trouble breathing, where if we take a piece of the lung, it would affect their breathing, or there are other issues where we cannot have the patient safely treated with surgery. And that's a case where radiation is a very good treatment for stage 1 or 2 lung cancer. And so, these are different types of surgeries that patients can have. So sometimes the surgeon can cut a little snippet out. That's called a wedge resection. This is not what we usually want to do for lung cancer, but for some patients who have multiple spots, we will sometimes do that. This is a segmental resection. This is a very good treatment where they take just a segment of the lung. So the lungs each have different lobes. So you may have heard about, well, my right lung has 3 sections or lobes, and my left lung has 2 sections or 2 lobes. And within those lobes, there are also little segments. So sometimes they can take a segment out. If the tumor is bigger or closer to the middle of the lung, they will have to take out the whole lobe of the lung. And in rare circumstances, we sometimes will take out the entire lung. And so that is a discussion with the surgeon about what's safe and what's best. And for patients who can't have surgery, they can have something called stereotactic ablative or stereotactic body radiation. And it's something that I do a lot for patients who are not able to have surgery. And we can see this is an example of a tumor that we treated with radiation. This was before radiation. And after radiation, the tumor got smaller, and it basically forms a dead scar. And so there are some differences between surgery and radiation. For surgery, they'll take it out. And for radiation, we leave behind a dead scar. So when do we combine treatments? And we talked a little bit earlier about the stage 3 and later 2 cancers. And these are cancers that have spread to the lymph nodes. And when it's spread from the lung into the lymph nodes, and the lymph nodes are little tiny organs that line your airways and other parts of the body that really are the garbage stations of the body. But sometimes cancer cells hitch a ride into those little garbage stations, and they form a tumor in the lymph node. And that's when it becomes a stage 2B or a stage 3. And when that happens, we can't just cut things out or give radiation. We have to give some drug treatment to address the pathways that these cancers hitched a ride, and we want to prevent new spots. And so this is where we combine surgery and drug treatment, sometimes chemotherapy and immunotherapy, or in patients where they can't have surgery, we will often do chemotherapy and radiation and add immunotherapy. And so this is why it's really important, again, to have a team We call it multidisciplinary, meaning everyone's from different specialties. We all specialize in lung cancer, but we specialize in using a certain type of treatment for the lung cancer, where we put our heads together with the patient and we sit down and say, look, looking at your medical history, looking at where the cancer is, looking at how well your lungs are working, your heart is working, this is probably the best treatment for you, because there's multiple options and there's different ways to treat patients with the same outcomes. And we want to make sure everyone makes an informed decision. And so you can see it can be quite complex. This is actually excerpted from our NCCN guidelines. And you can see they've got all these tables and arrows, and there's lots of different pathways we can go down depending on the type of non-small cell lung cancer. And also we do a lot of genetic testing for patients in 2B and stage 3. And Elsa will talk a little bit about different drugs depending on the genetic makeup of the tumor. So it's really important to involve the whole team and have a whole team that discusses your care. So for stage 4 lung cancer, there are also lots of different treatments. They're all different types of drugs that we can use, and Elsa will talk a little bit more about that. Radiation is also important as well. It's actually very important for the treatment of stage 4 lung cancer. And I'm going to talk to you a little bit about the radiation process next, but basically what we're doing is we can use radiation to target spots that hurt or are bleeding or are blocked up, so that we can open them up, stop bleeding, or help with pain. Sometimes if patients are on a really good drug treatment and everything's responding except for one spot that's just going rogue, then we also target that very aggressively with radiation, so that it doesn't give rise to other rogue tumors, so that patients can continue on their current drug treatment. And then sometimes, we have patients who have cancer that's a little bit too much for us to do surgery or radiation for. So we give them drugs, and when things shrink down, we target what's left behind, often with radiation, to kill what's left behind. And sometimes that means we can give people a break from their drug treatment as well. So there's multiple ways in which radiation can be used. So what is radiation? Everyone's really scared they're going to glow in the dark or acquire superpowers. Unfortunately, I don't give anyone superpowers, and nobody glows in the dark. I hope they don't. And you're not radioactive after any of the treatments. It's basically the use of very, very well-controlled X-rays, or we can use particle therapy called protons, and I use both here at Mayo Clinic, to target a tumor. So this is an example of the type of machine that can be used. This is our CT scanner. And then this is actually one of the radiation machines we have. And this is an example of what the radiation looks like to me when my team does the calculations for the radiation. In reality, when you start radiation, we start with a CT scan so that we can do our calculations within the radiation oncology department to very accurately target the treatment. And so it's called a simulation. That means we're putting you in the position we need you to be in for the radiation. And so these are examples of the types of devices we use. So sometimes I have to put people in a mask that bolts them down. Sometimes I put people in a bean bag. I very seldom vacuum seal people in, like in this picture, but we do use a bean bag to keep people still in the same position every day. And radiation treatments are usually given once a day, every day on business days, except for weekends and holidays. So what does it feel like to get radiation? You don't feel anything. It doesn't feel, taste, or smell like anything. All we need is for the patient to lay very still, because everything is programmed into this machine. We have radiation therapists who will drive a machine that will target the radiation exactly where we need it to go. And nobody's radioactive, as I said. Nobody gets superpowers. Nobody glows in the dark. But there are side effects. And so I'm going to concentrate mostly on lung side effects. The side effects are usually temporary, but this is another picture. This is actually a proton radiation plan for lung cancer that's stage 3. And the red is where the high dose has to go, because that's where the cancer is. My goal is to kill that cancer. And buried in all of this is also other organs, and the organs get temporarily burned by the radiation. And this is why we have side effects, because there's that temporary burn as we're killing the cancer. So it's very common for patients to be very tired. It's very common to sometimes have a little bit more of a cough if we get some inflammation. Trouble swallowing is not uncommon if the radiation has to touch the swallowing tube, and we have lots of medications. Nausea can happen if the radiation skims the stomach or the liver. Sometimes patients can have a little bit of discomfort or pain, especially if the tumor is touching a rib and we have a lot of radiation that has to go through a rib or the spine. And sometimes you can get very red skin. A skin burn is very uncommon with X-ray or photon radiation, but it is much more common with proton radiation. So generally, when a patient has radiation treatments, they do see their doctor regularly. I see my patients once or twice a week. We manage the side effects. They're generally temporary. And then again, because of that multidisciplinary care, we work with everyone, our chemotherapy doctors, the radiologists, the pulmonologists, or pulmonary medicine, everyone to manage everything because you maybe have receiving multiple treatments at the same time. So what happens after the treatments? So it's very important to emphasize survivorship. I think that, regardless of what stage you are, after the treatments, then we have to go and do surveillance, which means we have to watch and make sure things don't come back in the same spots that we treated or in other spots and it hasn't changed or spread. And typically we will scan every 3 months. And as you get further and further out, so 2, 3, 4 years out from your diagnosis, so when you finish your treatment after you were told you had lung cancer, then we may see you less frequently. So I have patients who I see now once a year and, they're 5 years out and they're very happy they're like, "Doc, I like you, but I hope I never have to see you. I'm glad I don't have to see you as much." And we really want to get you to that point in survivorship. I think it's really, really important to go for your follow-up scans. It can be very onerous, but it is really important for us to keep track of things and work within our team to make sure we don't miss anything that might come back. And the chance of things coming back really depends on the stage, but regardless, we do have to do surveillance. So I think that is all that I have. I've tried to give you a general overview of what it means to have non-small cell lung cancer, what types of treatments are available. But I think the most important thing is to have a really good team who is collaborative and who talks to one another so that you and them can sit down and come up with the best plan for you. So I'm going to pass the baton on to my colleague Elsa, who's going to talk to you a little bit about the drugs that we use for the treatment of non-small cell lung cancer. Thanks very much, and I look forward to taking your questions after we've completed all of our talks.
Thank you, Dr. Owen, and thank you everyone for joining today. Really excited to be here. And want everyone to know that being here is really meaningful. As Dr. Owen kind of explained the course of diagnosis to treatment options, and you can see how many people need to be involved in care. It's kind of like drinking from a fire hose to learn and understand what's going on. So thank you for being here to try and learn more, and hopefully everyone can learn something from today. I will be talking about systemic therapy options, as Dr. Owen mentioned. So in medical oncology, I treat people with medications that are going to affect cancer cells really wherever they might be in the body, compared to radiation treatments or surgery that are local treatments that will only target kind of where they can touch. So commonly this looks like chemotherapy, drugs called immunotherapy, and some drugs called targeted therapy. A lot of the time, it's a combination. And so again, you saw how many kind of different pathways there are that are really based on, your cancer diagnosis, where things are, your past medical history. So a lot of the times we have a combination of chemotherapy and radiation, chemotherapy and immunotherapy, chemotherapy and targeted therapy, before or after a surgery or radiation. And so I will do my best to cast a wide net, knowing that things can be very specific, and would love to go into detail for everyone's specific case, but again, we'll try to kind of be broad in how we think about systemic therapy. So chemotherapy, as Dr. Owen mentioned, it's really important for us to have a biopsy. She might be laughing because The thing about medical oncology is we always need tissue. We need to know in order to give you the best treatment what kind of lung cancer this is. We won't be talking about small cell, but here I put adenocarcinoma, squamous cell carcinoma are some of our most common non-small cell lung cancers. Generally, what I'll educate patients about is that chemotherapy kills quickly growing cells. That's primarily going to be cancer cells that are just dividing. Therefore, our side effects are going to be on some other cells in your body, kind of innocent bystanders that grow quickly. So your bone marrow churns out different blood cells, so red blood cells, white blood cells, and platelets. Some specific chemotherapies compared to others will impact hair follicles. You get a haircut, it grows back. Sometimes some of our chemos are a little bit more aggressive on impact on hair. Your cells that line the GI tract turn over pretty frequently, and sometimes we can see nausea as a side effect. The chemotherapy is so general. If you pulled me up on the street and you said, I'm getting chemotherapy, it's not entirely meaningful to me unless I know exactly what the drug is. And so there are very different side effect profiles based on the specific drug. So sometimes I'll meet patients who are, understandably nervous about getting chemo, but a lot of the times maybe it's because they themselves had breast cancer previously, or they know someone who had lymphoma and have seen people receive different kinds of chemo. So specific to non-small cell lung cancer regimens, typically we'll see that the chemotherapies I give can cause some fatigue that can happen over time with cumulative doses of chemo. Sometimes there's nausea. I think we do a pretty good job nowadays with nausea coverage. We make sure you have drugs at home to take care of this. It's really more often than not that sometimes people don't really need some of their nausea medication. So I tell people don't expect that your head's going to be in the toilet with some of these treatments or anything like that. On occasion, depending on treatment, there can be mouth sores. I say diarrhea and constipation, opposite ends of a scale. I think patients can kind of see either. And it's so important, you'll hear me say this multiple times, to communicate with your oncology team about how to manage those things. Specific to certain kinds of chemotherapy, you can have numbness or tingling in fingertips or feet. That's called neuropathy. And the main thing here, this decreased blood count, is kind of that effect that the chemotherapy can have on blood counts, where we see that once we give you the drug, we drop your blood counts, and with some more time, kind of further out from the date you had chemo, they kind of work their way back up. Chemotherapy for non-small cell lung cancer can look a little bit different. I wanted to highlight the difference between chemotherapy we give in a 3-week dosing versus weekly chemotherapy that's usually given with radiation. So very often the patients I share with Dr. Owen will be getting a 6-week course of radiation, and we help out by administering weekly chemotherapy. So the differences are going to be every 3-week chemo is kind of this bigger dose. It's this killing dose of chemo where we're really going to have a big effect on cancer cells. With the bigger dose, that can kind of come with a little bit more side effects. The weekly treatments with radiation, what I'll tell patients is that, Dr. Owen's radiation treatment is the workhorse in trying to kill cancer cells right now. And the weekly chemotherapy is really the supporting actor, helping the radiation work better. So again, with a lower dose, there's typically fewer side effects than compared to the 3-week dosing. And again, we pick these based off of, do we think you can tolerate them? How fit are you? Are you up at home doing things normally? Are you really, really sick? Do you have a history of hearing loss? Sometimes we can consider differences in treatments. There are a few that we use that can cause hearing loss. We think about how your kidneys work. Some of our chemotherapies compared to others can really affect kidney function. And have you had other treatments and kind of how did you tolerate those? All of that, again, it's very personalized, helps us come up with the best treatment plan for you. So this is a chart I'm hoping that will be helpful, kind of delineate the differences between the 3-week dosing and the 1-week, every 1-week chemotherapy we give with radiation. I will say here that in treatment goals, a lot of the 3-week chemotherapies, we're actually using that more and more in the early stage cancer setting. So a lot of times we'll have patients who are a good surgical candidate with an early stage lung cancer, and we're finding more and more that we use that 3-week chemotherapy, often with immunotherapy. We give patients some treatment, then they go to a surgery, and then they get some immunotherapy after, and it's helped them do better compared to just cutting things out immediately and giving them some treatment after. So a little bit about immunotherapy, super hot topic. Drugs like Keytruda are advertised, on your TV. Essentially what this class of drugs does is uses your body's own immune system to fight cancer cells. So I kind of tell patients it works kind of in 2 ways where, your body is supposed to recognize that cancer cells should not be there and kind of go after them, take care of them. But sometimes they can kind of wear this cloak of invisibility where your immune system is just going around and can't tell that they're there. So the immunotherapy can kind of go in, revs up the immune system, and yanks that cloak of invisibility off of cancer cells so your immune system can see it and take care of it. So if the way this drug works is to use your body's immune system to take care of cancer cells, side effects are just going to be that your immune system mistakes cancer cells for potentially another organ, and will cause inflammation of that organ. So I have here itis or inflammation of any organ. Really what I emphasize for our patients is making sure, for these side effects, the biggest thing is reporting symptoms so your team, can know, do we have to be worried about this? What's going on? The big things I educate are inflammation in the lungs from treatment can be very serious. You might experience more shortness of breath than normal or an increased cough. That's a phone call to your treatment team. Inflammation in your colon might produce something like 4 to 6 or more loose watery stools daily, which can be very dangerous for dehydration. It can make people very sick. That's a phone call to your oncology team. Dermatitis or inflammation in the skin can present as a really mild rash. So sometimes people get away with creams and some antihistamines, but sometimes it can be as serious as having blisters. So about 15 to 20% of any, a patient can have a side effect, and they range from mild, moderate to severe. The biggest thing is that we educate you about it, about the ones you might feel. We check your blood work every time you get treatment. You'll see that last bullet, inflammation in the kidneys, the liver, the pancreas. We're watching for some of those side effects you might not feel. Then you heard me mention about targeted therapy. So this is a very exciting field for lung cancer patients. We're finding more and more that as the incidence of smoking is going down, smoking-associated lung cancer is going down. But there is a rise of lung cancer in patients who have never smoked. And often we find that it's related to some of these mutations I have listed here, for example, EGFR, ALK, ROS1. And so these are specific mutations in the tumor cells. And so something to clarify, how do we find these? We do genetic testing on the tumor cells, and that's not genetics as in from my parents, to me, to my children. It's simply, we take a piece of the tumor, we want to look for any of these examples I have listed here, for these mutations. These mutations in particular, we have very specific treatment for. So that's why we want to look for them and find them. And sometimes people will ask me, is it better or worse to have one of these? That's always challenging. We don't want you to have cancer at all. And it's not so much, better or worse. It's just we need to know everything about the tumor to treat it the best way. So if you don't have an EGFR mutation, you just heard me talk about chemotherapy and immunotherapy, which are great treatments. It's just that if you do have one of these mutations, we have very specific treatment for it. And so a lot of the class of drugs for these targeted therapies, they're often in the form of a pill. Diarrhea, sometimes an acne-like rash, and potentially brittle skin or nails that kind of fall apart. But otherwise, usually tolerated pretty well. What I didn't mention on my first slide is that beyond chemotherapy, immunotherapy, and targeted therapy, whenever we're looking at starting a treatment or changing a treatment, we always want to be thinking about clinical trials. So I included some slides here about what is a clinical trial, and what I really want to say to you who are joining us today, all of the treatments that I just talked about were once upon a clinical trial. Essentially, we are, whether you are a patient, whether you're the loved one of a patient, we are working really hard to find better and better ways to take care, of our loved ones, of our family members who are diagnosed with lung cancer. And so a lot of this involves, an idea that starts from understanding this biology into how do we deliver this drug to people? Does it work? So that's often how I explain clinical trials to people. It's an opportunity where you have access to potentially the latest treatments. We're contributing to trying to find better treatments in the future and help us understand, how these treatments work. So essentially, how might you participate in one? I think it's important to always ask. At Mayo, we always screen our patients for trials. And the thing too is it's not just like I have a patient and I'm gonna, here's a clinical trial, throw them on one. We find one that's a good match, one that we think, makes sense and might work. So you have to be eligible. Sometimes it has to do if do you have a mutation. Again, with that tumor genetic, all those genetic markers, would this be a good fit for the trial? Past medical history, things like that are important. We talk to you about a clinical trial. And often, sometimes they involve some time cost, right? Where if I have a trial at Mayo and you live in California, but there's the same trial in California, it can often be a lot more visits because you're watched closely. So it's important too to think about, how often do I have to be seen? Here we go. My slides aren't going. So benefits of participating in a trial. We talked about cutting edge treatments, contributing to the future of cancer care, close monitoring. Potential risks are, we're studying this. This is a part of a trial to see if it's effective. You are monitored very closely where if something's not going the right way, we stop, we restage you, we make treatment decisions from there. The other component is, potentially looking at some side effects or reactions, but again, very close monitoring in the setting of a trial. Again, I'll say talk to your doctor about clinical trials. Another good option is looking at things like clinicaltrials.gov as a resource for you. And if you remember only one thing from my contribution to this today would be to always communicate with your oncology team. We're here to support, patients, their families. Again, all of this is trying to drinking from a fire hose. And we want to make sure you're well educated, that you're well supported, and that you have a good understanding and feel comfortable with your treatment plan. And with that, I have the pleasure of handing it over to Terry Shapiro.
Thank you. Thank you, Elsa. And welcome everyone to what I hope will be a very useful webinar for all of you. My story began some years ago now with a shocking diagnosis of non-small cell lung cancer. I had a spring allergy cough that just didn't clear away, and I went for an X-ray, and eventually this diagnosis was brought. It was like being struck by lightning. And not only did I have lung cancer, but it was staged at 3B, which is almost as bad as you can have. And accordingly, based on everything that you've heard so far, stage 3B really is the stage that requires or involves multiple different kinds of treatments. And I had just about every treatment that was available at the time. It started with chemoradiation, which lasted for about 2 months. I had a 2-week rest after that before going for a very extensive surgery, took out half of my left lung, part of my heart, and several great vessels. And not much recovery time after that. I started on consolidation chemo for a couple of months and then went on to maintenance chemo for about 5 years. This was fairly standard therapy at the time with the drugs that were available in those days. I missed time from work. I was quite ill at some points, and I learned many lessons along the way, which I'll share with you, and that I hope will be helpful for you to hear about. So the first thing I think you need to do is dig down deep inside and decide what your attitude is going to be toward this diagnosis. This is an exceedingly personal decision. This is one of the most personal decisions you'll ever make. And you have to take an attitude toward this diagnosis. Are you going to be aggressive? Is this war? Are you going to do every possible thing that can be done? Are you willing to fight as hard as you can on the one extreme? Or at the other extreme, are you elderly? You've had a great life. You have 3 or 4 other illnesses. You live far from the hospital. You really don't want the trouble and the pain that comes with being aggressive against this disease. And you just want to live out the rest of your days as gracefully with this thing as you can. So these are 2 very extremely different attitudes, and there are zillions of options between those 2, but really you need to do this early on after the diagnosis because it's going to dictate everything that happens to you afterwards. And in some cases, it's not very easy to reverse this decision. This is clearly personal, but you need obviously to involve the people who love you, your family who care for you, and you need to partner with your medical team. You need knowledge in order to make a good decision here. One of the other first things you need to do early on is what I call get a grip. Getting a grip is a mechanism or mechanisms for you to kind of be a little bit in charge. It gives you time to get acclimated to this diagnosis and to be effective in dealing with it. And you need to get a grip medically. You need to have a to-do list, a calendar. I have these appointments. I have these pills I have to take. You can keep a diary. I have these toxicities. It keeps you busy doing this. It keeps you focused. It's a good thing. You need to make for yourself and your family a list of important contacts. Get it on paper. Put it in your pocketbook, put it in your wallet, put it on your bedside table. Who do you contact if you suddenly start coughing up blood, or if you have a very high fever, or if you lose consciousness, on a Saturday evening, which is when these things typically happen? Don't leave your family struggling to know what to do with you. Give them easy to find contacts. You need a treatment notebook, a diary, keep track of what you're taking, what you have taken. If you go for another opinion, you want to be able to say to the other doctor, look, I've been on this chemo and I've been on this radiation. And take notes at your doctor's visits. There's so much information coming at you from many different directions. You can't hope to retain all this information just in your head. So try to take notes when you're at a doctor's visit. You also need to get a grip personally. And truth is, probably all of us should do this, whether we have lung cancer or not, but certainly you need to do it if you have lung cancer. And that is to make, if you have a job, to make arrangements and figure out what options are available to you. Do you have medical leave? Do you have short-term disability, long-term disability? There's a FML, federal program available to you. You may not need any of these things, but you should find out what your options are there early on before you get into heavy-duty therapy so that you can tap these resources if you need them. You need to get your finances in order. How much do I have available to help support me with this? Can I afford taxis every day back and forth? You need to have a living will. Don't go into the hospital. Don't foist this on your family and your caregivers to decide whether you should, be resuscitated. This is your decision and your responsibility. And finally, of course, you need a personal will. And as I've said, whether or not you have lung cancer, probably you should be doing these things, but you certainly need to do them if you have this diagnosis. Among the other lessons I learned was that I needed support. I always brought someone with me to my doctor's visits. So very many important things happen in that conversation, and it's hard to take it in. It's so helpful to have a second person to help you retain the information and to help you ask the right questions at the time. People will, it's incredible, the people who will come to you and offer to help you. Can I be of any help? Can I make a meal? Can I run you to your appointments? Accept these offers. I'm a very independent person, but I learned that I needed support and I learned to accept help, and it made the person offering the help feel better about things. They were doing something positive. And often these offers come very generally. If there's anything I can do, just let me know. You look that one in the eye and say, do you really mean that? Because I may want to reach out and ask you, to take the dog to the vet or write my checks out for my bills every month. So accept these offers and learn to lean on your family and friends. Maybe you were always the strong one, but at this point in time, you need to lean on people and accept help. Knowledge is power. You have many resources available to you, and kudos to all of you because you're here today tapping resources. You have your doctors, your nurses, your social workers. There are local lung cancer advocacy groups. Make the best of all of them. Questions. Ask them and get answers. The internet now is very different from what it was when my diagnosis was made. And I think it can actually be detrimental. There are you can spend your 24/7 on the internet probing all sorts of places. My suggestion to this is that you pick a couple of really premier, reliable internet sources like GoTo Foundation, NCCN, or the National Cancer Institute, and read them thoroughly and assimilate and understand that information. And don't spend all of your good time focused on the internet and trying to figure out every little widget that's available to you. The other thing about knowledge is power is second opinions, and I can't underscore this strongly enough. Your doctor will not feel threatened or insulted that you're asking for a second opinion. You need, and I credit my being here today with the fact that I had second opinions on whether or not I should have surgery. So I strongly, particularly early in your course, to seek out and get at least one, if not more, second opinions, to feel confident about your diagnosis and your staging, and to feel confident more difficultly with crafting a plan going forward. So one of the key lessons I learned was that I really I really wanted to be sure that 6 months or a year or 2 years down the road, I wouldn't look back on what happened early on and have regrets. Oh, I wish I'd gone for that surgery. Gee whiz, I should have just strengthened myself and taken that chemo. You can't return for some of these things. So be mindful early on when you're making your decisions and when you're taking your position of whether this is war or not, about just whatever decision you make, 6 months from now, a year from now, you can look back and say, well, I wish things had turned out better or turned out differently, but I did the best I could at the time. You want to be at peace with yourself about this and not have regrets. And finally, believe it or not, you have very many good fortunes and you should be appreciative of them. You have a lousy diagnosis, I get that, but there are silver linings. And you need to appreciate the people that you're leaning on for support, and thank them. And don't just dash off something on an email, thanks for the dinner. Go get thank you notes and send somebody to a post office to get you stamps and sit and write something thoughtful. It takes time, it keeps you occupied, and it makes you realize that you should be grateful to people who are helping you. And finally, I think it's important to recognize that you are incredibly important to be living in this country. We have the best medical care in the world, and medical care continues to advance. I look back at the therapies that have come into vogue that you've heard about today. Many of these were not available to me, and many of them are very much more effective, and they're very much less toxic than some of the therapies that I took. So be grateful for having the best medical care in the world and make the most of it. Finally, I thought I would just list a couple of questions that are common, and just to get the juices flowing about things that you might want to look into. You need to be clear exactly about what kind of lung cancer you have and what the stage is, because everything that happens to you after that depends on these things. You need to understand your treatment options, and this can be exceedingly complicated, and very many different modalities are available. And this is kind of where the art of medicine comes into play. It's fashioning the best treatment plan, and requires you and your family and good communication with your care team. You need to understand maybe the extremes. What if I don't do anything? What's the natural history of this disease? Or on the other hand, the more aggressive, can you cure me? What are the chances of me getting a cure? Obviously, you need to know about the complications and side effects of the treatment. And clinical trials have been mentioned, and you may need to think about that during the course of your care. And finally, there are financial implications here, and you need to be realistic about them. Maybe you need to ask, what are these drugs going to cost me? And, how much will my insurance cover? So there are very many types of questions you can ask and that you should be asking. And that closes what I had to say to you. I wish each and every one of you all the very best in your journey to come. And I'm going to turn it back now to Tanya to lead the question and answer period. We're here for you. Ask us a lot of questions.
Okay. So I'm going to start by reading some of the questions. So we're going to start. It's wonderful how rapidly new drug treatments are being discovered, tested in clinical trials, and approved for lung cancer, but it raises the following questions. What is the best course of action when you're already on a drug for non-small cell lung cancer and then a new drug is approved that has a significantly better overall survival? And should you switch to the new drug or continue with your current drug as long as it is still working against the cancer?
I can take that.
Okay.
So again, while I can't give direct medical advice, I see this question sometimes in patients that have a targeted therapy called ALK, where there was a study that came out about a specific drug called lorlatinib, with some patients already on a drug called alectinib. And we typically, if it ain't broke, don't fix it is often how things operate. It really depends on a case by case basis. But typically, if you're tolerating treatment well and things are going well, we don't often make a change. That brings another point of, we really often don't make treatment changes unless there's disease progression, right? Like the treatment isn't working or it's not tolerated. So again, I'll tell my patients in the metastatic disease setting that, we're going to start this treatment, it's going to be long term, where as long as you're tolerating it and as long as it's working, we typically keep going with some very occasional caveats to taking treatment holidays. I hope that answers the question.
I think so. This other one is, I am a patient, EGFR stage 4, and I'm wondering about supplementation and strict diet. Do either have a worthy impact? And if so, what are some options on supplements?
I typically recommend against any supplements. And I'll tell my patients, I get this question a lot, like, what can I be taking to do the best? And it's your current cancer treatment. I don't have any evidence that specific supplements are going to help, that there is a diet that's going to be better. So we typically tell patients eat healthy and well, right? Try to maintain an active lifestyle. I only have so I'll get questions about high doses of vitamin C. We often discourage against that. Questions about ivermectin use with treatment. I usually discourage against that. Or hyperbaric oxygen. Sometimes all those three in a row come up. And I don't have any evidence that those will be helpful. I also worry about how they might impact the treatment that we're giving, and potentially making it less effective. And so no like collagen peptides, typically no supplements. I also worry that sometimes they're really expensive. And for some patients that, it's really not affordable and not helpful.
Did you have anything to add, Dr. Owen?
I share similar concerns. So actually, we have at Mayo, we're lucky we have a great integrative medicine program, and we have patients bring in all of the supplements that they're taking. So we can go through it with the pharmacist. We can look at ones that may or may not be continued. There is some evidence to suggest that high dose antioxidants can offset the efficacy of radiation. And so we have to be really careful. The difficulty is that a lot of the supplements are not regulated. They have not been studied. So all of the drugs that many patients are on have been the subject of these big clinical trials, where we have learned from patients who have volunteered, patients such as, who have said, okay, I'm going to volunteer my body and I have cancer, and I'm going to see if these drugs work or not. Those supplements have not been vetted in that way. And we have seen some unusual complications because of interactions. Also, the dose of many of these supplements is not regulated. It's highly variable. For example, recently in the news, there have been concerns about melatonin overdoses in children because, again, that is not regulated, whereas a drug that is manufactured by a pharma company, they will recall drugs if they don't meet certain standards, if they're potentially harmful. That doesn't happen in the supplement industry. So I think that it would be very important, as Elsa said, communicate with your oncologist. Terry has talked about how it's really important to take notes, talk to your doctors, bring your concerns. And so I do have patients, for example, one patient was on milk thistle, and generally that's actually a diuretic, and he became extremely dehydrated during one of the treatments. And so it's important for us to know what you're on, and we can work with you. Sometimes I just say stop it for duration relevant to me for radiation, and then you can start it up again because I'm not sure how it interacts.
Great. Did you have anything to add to that, Terry?
No, I don't think so. It's not easy to eat. Not easy to eat healthy anyway in our society, but this is among the supports that you can ask for, your favorite foods and, somebody to just be there for you and see that you have the nutrition, whatever you can tolerate.
Mm-hmm. I would say we've done other webinars, and this is a common question. And so, from a writing standpoint, and I know from a physician standpoint, you just want to tell your care team, like, this is what I'm thinking about taking, this is what I'm taking. You should feel comfortable to speak up, to just share like your concerns. I think because we're all just trying to do whatever we can to be better, right? And I think our society is like, oh, we take vitamins to feel better, to be better. But then once you have a cancer diagnosis, things kind of change and the rules don't necessarily apply um, the same way. So I think this is a great question, good discussion. Okay, so I have stage 4 metastatic non-small cell lung cancer, adenocarcinoma, EGFR, exon 21, L858R. I've had one radiation treatment for the brain in November 2020, and I've been taking Tagrisso since December 2020. I now see my oncologist every 5 months. If everything continues to remain stable, do I take the Tagrisso for the rest of my life, or when can I expect to take a break from taking the medication? At this point, side effects are generally tolerable.
I think I might have answered this earlier. Again, this is a personalized decision with your oncologist, but typically in the metastatic setting, especially for Tagrisso, that has good penetration in the brain, and if you're tolerating it well, something that we might expect to be taken very long term. But again, it's very personalized, right? We are the GPS, but you're driving the car. So I think if you have concerns about continuing it, it's worth a discussion with your oncologist. But again, typically we like to continue medications as long as they're working and tolerated.
Thank you. So Dr. Owen, this one is for you. Are you familiar with CyberKnife radiation? And I'm guessing
I am
someone wants to
familiar
learn.
with CyberKnife. So CyberKnife is a brand name of delivery of a type of radiation that any radiation machine can deliver called stereotactic ablative or stereotactic body radiation. And so it's not, there's nothing special about a CyberKnife. The way that it delivers radiation is a little bit different than traditional linear accelerators, that's the way most X-ray radiation is delivered, where we pump electricity through a machine, it hits a special source and it generates radiation that we can program and manipulate to target what we need to target. The unique thing about a CyberKnife is that it can track things. So certainly there are lots of reports of patients who had CyberKnife stereotactic radiation to the lung, and they decide to play with their breathing to see the CyberKnife machine move in a different way to track their breathing. But otherwise, there's really nothing unique in the way that the radiation works. It's still X-ray or photon X-ray radiation. It's delivering high doses stereotactic radiation, which can be delivered by other linear accelerators. And the outcome, so the control of the cancer, is the same.
Thank you. So this next one is about financial support. So thank you to all of our presenters. Great job, Terry. Thank you for sharing your journey. Very inspirational. What financial support do you have for people who are in the donut hole where the financial support from pharma is limited? Any suggestions?
It's certainly challenging, in this field. It is shocking to me how much our drugs cost. If you're talking about the donut hole, I'm wondering if you're talking specifically about, the outpatient cost of other drugs that you need. Best recommendations are to reach out to your oncologist to see what options are at your institution. We have financial counselors here at Mayo. And sometimes, we can find GoodRx coupons for patients with certain medications. But I think seeing, with how individual insurance is and different institutions, I think it's probably best to start by looking locally and asking what support that they might have.
Thanks. So another question. Stage 4, non-small cell adenocarcinoma, diagnosed in July of 2014, EGFR exon 19, and have been on afatinib for almost 10 years, mostly stable. Has there been a study as to why some people respond exceptionally on specific drugs?
Hard to answer that directly. I think that it's again, things are so individual. This of afatinib, if you were diagnosed in 2014, was what we knew was best at the time, and we've certainly done more studies. And we actually know that even within EGFR, you can have a lot of different mutations or certain proteins where drugs act. Can, even if tiny molecules are shifted in a certain way, can change like binding properties of drugs. So it's a really complicated question. I don't have a perfect answer, but I think it has a lot to do with some really complex biology and pharmacology is my best answer for you.
So we've had a few more questions just about, do I have to be on these drugs at the same dose for the rest of my life? And I feel like we've answered those a couple of times. So this one is about, let's see, I had 6 weeks of radiation, 4 rounds of chemotherapy with carboplatin and permethrin, as well as 15 months of Imfinzi. 2 years of scan have shown no disease. Now seeing, let's see, now seeing disease in the lymph node, right hilar. How do you determine if this means it's a recurrence, infection, or inflammation?
That's a really great question, and we do encounter this. We don't expect things to grow 2 years after chemotherapy and radiation. We would be concerned. So the first, it sounds like perhaps they've done a whole body scan, a PET scan, and usually the way we attack it is, can we biopsy it? It really also depends on what it looks like on a scan. And so here at Mayo, what we do is whenever there's any concern for an unusual finding after a patient's had a long time of stability on scans, is we have a multidisciplinary discussion. So again, we talked about having the whole team. We have our radiologists take a look at it. Do they think it looks suspicious? And certainly growth is potentially suspicious. Does it look spiky? We call it speculations. How fast has it changed? So for example, if things have kind of grown suddenly over about a month, and there's also lots of inflammatory changes, which usually looks like little clouds in the lung, it's probably infectious. But ultimately, the key is, in these scenarios, we talk about, do we do short-term follow-up? Do we do another scan in 4 to 6 weeks to see if things are settling down? If it looks more infectious, if the radiologist thinks that's the case, and we may start some antibiotics. And if it's still there and we're still worried, then we would look at doing a whole body scan if a PET scan hasn't been done. The problem with the PET scan is we can't tell the difference between inflammation or infection. Everything can light up. And so what's really important is to look at the trajectory of the scan. Is this the first scan where we've seen this? Then we sometimes do a short-term follow-up to see, well, is it still changing? If it isn't, then it might have been a one-off. Because if you had a cold recently, due to this, right before the scan, if you had any sort of infection, it can cause the lymph nodes to light up. If anybody has a history of any heart problems or other lung problems, the lymph nodes can also get big temporarily. And so this is a very difficult question, but ultimately the way we tell if we're worried is we have to biopsy it. And so if it is hilar, hopefully it's next to an airway, and very often we'll have our pulmonary medicine colleagues take a look to see if they can put a camera in there and take a look and get a sample.
And so there's, if you're reading the chat here, this question, this background is a little long, so I think I'm just going to, it seems to me, that if someone's had surgery 8 8 years ago, never smoked, and then you're seeing, let's see, that there might be recurrence, I guess, and the biopsy is inconclusive. Like, where do you go? I think this is an example of someone whose things don't seem clear. They're not sure when the genetic testing takes place. So what would you recommend?
I think that again, if there's any confusion, I think
Mm.
you need to do what Terry said. Go to another institution, get a second opinion. Because what happens, you get fresh eyes that look at things. And I'm never upset if somebody goes for a second opinion. I had a patient who fact checked what I wrote in my note and went to the principal investigator of the that I quoted in my note to get a second opinion. He did agree with me. He's one of my colleagues at another institution. And ultimately, the patient decided to come back and have treatment. I encourage patients to go get a second opinion because if you have the same people staring at the same thing, sometimes having a fresh set of eyes means maybe starting afresh and getting new information or looking through the information with a different perspective and saying, oh, what if we do this? And the question about the genetic testing, and Elsa can jump in, is that we don't typically do genetic testing for stage 1 lung cancers. It's often not covered by insurance. We don't have any FDA approved therapies after you've had surgery or radiation for stage 1 lung cancer. And even if you have the EGFR mutation, there's a study that's still going on. We don't have the approval to give it to someone to prevent a new spot. And so I think the main thing here is if the biopsy is inconclusive, typically what we do is either if it's very, very suspicious, we try again. We might go through a different way to biopsy it. Or maybe the reason it was inconclusive was because the nodule is also inconclusive on the scans for recurrence. After radiation, things can look bigger temporarily before they get smaller. Everything gets really, really inflamed. And Terry, firsthand experienced all the horrible inflammation that probably the radiation doctors cause and the side effects. And so I think that I would encourage you to think about that at this point, to have somebody else review all of the imaging, go see another doctors, another institution, figure out if there's a way to biopsy it, or sometimes we just watch it and we see, is it changing enough that we can get a better biopsy? Because if things are really small or they're wispy, it's actually really hard to get a little needle or a big needle and to get a piece to look at under the microscope. So I'm congratulations on having been a cancer survivor for 11 years. But I do think that this is a good scenario to kind of think about that.
Great, thank you. So we are out of time for today. We would like to thank everyone for attending. I know we didn't get to all of the questions, but I think we did answer in some ways all of the questions. The NCCN Foundation would like to also thank the corporate supporters of this webinar. Just a reminder, the recording will be available on our website. In April, we will have a small cell lung cancer webinar and a clinical trials one in February. All the information can be found at nccn.org. Thank you again. Thank you so much.